Hi, I'm Dr. Silva, and I'm here to talk to you about MAOIs, monoamine oxidase inhibitors. Monoamine oxidase is an enzyme in the body that helps to promote the catabolism of monoamine neurotransmitters, serotonin, dopamine, and norepinephrine. What this enzyme does is it promotes the catabolism of those, and that's one way that we can terminate the action. So when a neuron releases a neurotransmitter, and that neurotransmitter then acts on its target, one way that we can terminate the action when it's communicating with another neuron so that there's not this constant communication, one built-in brake, if you will, that the body has in order to maintain homeostasis is to break it down so that it's not active anymore. That's one mechanism. There are other mechanisms. Reuptake is one mechanism you may have heard of because the reuptake inhibitors, like the SSRIs, selective serotonin reuptake inhibitors, and the SNRIs, serotonin norepinephrine reuptake inhibitors, those are classes of antidepressants that work by blocking that reuptake so that when the neuron releases the neurotransmitter, instead of taking it back up again to terminate the action, that's blocked. So that's one mechanism. Another mechanism is simply to catabolize the neurotransmitter, and monoamine oxidase is the enzyme that does it. So a monoamine oxidase inhibitor would inhibit that process, and so you would have more neurotransmitter at the synapse. And so by interfering with the catabolism of these neurotransmitters, we increase their availability, we increase their concentration, and we increase their availability and their action. And that's one way to treat depression, is by increasing serotonin, increasing dopamine, increasing norepinephrine. It makes people feel better. And those different neurotransmitters have different effects in terms of target symptoms, but they're all good for depression when we increase them. And also, well, serotonin is good for anxiety if you increase it. Norepinephrine, not so much. Noradrenaline, not so much. But anyway, just in the context of talking about depression, I wanted to tell you that it's interesting because the first antidepressant, what could be considered the first antidepressant, was discovered, of course, serendipitously. Psychiatry used to be very much psychodynamically oriented. Symptoms were viewed as products of psychodynamics. And so psychiatrists, once upon a time, when we didn't have medications to treat illnesses, they approached it from a purely psychological standpoint as psychologists. And then in the 1950s, isoniazid was developed as an anti-tubercular drug. It was to treat tuberculosis. It happened to inhibit the enzyme monoamine oxidase. That's not something that people knew when they developed it to treat tuberculosis. But what they noticed was that those patients with tuberculosis who were receiving isoniazid became euphoric. They weren't depressed necessarily, but their moods elevated. They felt better. And this led to the development of, to the discovery, serendipitously, of isoniazid as an antidepressant, because it had monoamine oxidase inhibitory effects. Isoniazid was later withdrawn because it led to liver failure and kidney failure in some patients. But it led to the age of psychiatry in which we began to use medicines in order to manipulate the concentration of neurotransmitters like serotonin and dopamine. It's interesting that in psychiatry, initially, we discovered our medications accidentally. Chemists were trying to develop a certain class of drugs, but they weren't being very specific about what receptors they were targeting. They were dirty drugs in that they hit a lot of different receptors, and so one might be developing an antihistamine that happened also to block dopamine receptors, but we didn't care about that. That was just accidental. When they finally got to the SSRIs, they started to be very specific about, now we're going to be very selective, hence selective serotonin reuptake inhibitors. We're going to be selective. We're going to target just this receptor, and we're going to try not to hit any of the others, not to hit histamine or the muscarinic acetylcholine receptors, or et cetera, et cetera. And that's something that came later in around the 1980s, 1970s, 1980s, when those medications were developed. But early on, the monoamine oxidase inhibition was discovered as a mechanism for improving mood. And this led to the development of the MAOIs. The MAOIs, which include phenelzine, Nardil, tranylcypromine, Parnate, isocarboxazid, which is Marplan, which in the United States doesn't have a generic, and selegiline. Selegiline is special. I'll talk about that last because that one actually is a selective MAOI inhibitor. There's two isoenzymes of the monoamine oxidase enzyme, and that's A and B. So there's MAOA and MAOB. And most of the medications block both MAOA and B. They're non-selective throughout the body. And so that's what I'm going to talk about first, and then we'll talk about selegiline. So what are the side effects of the MAOIs? Dizziness, sedation, fatigue, insomnia, tremor, headache. MAOIs also cause weight gain. Weight gain can be significant. Nardil is the worst, Parnate is a little bit better, and selegiline is probably the best of all. We don't expect any weight gain or sexual dysfunction with selegiline. We see it a lot with Parnate, and even more so with Nardil. But what the MAOIs are fairly notorious for is causing orthostatic hypotension. There's another video that I do on that, but orthostasis is basically where you lose pressure, and specifically in the cranium, when you get up too quickly from a sitting or lying position, and you can get very dizzy with that because your pressure drops. You could actually fall, and in the extreme, you can experience syncope. You could actually faint, lose consciousness. And obviously, falling and hurting yourself, that can be very dangerous. This is a dose-dependent phenomenon, meaning the more milligrams of the medication you take, the more pronounced this side effect is going to be, and it's also exacerbated by dehydration. So you got to be very careful when you move, and you got to stay well hydrated. Weight gain is not dose-dependent, and we see it more, again, with phenelzine than with tranylcypromine. So when it comes to weight gain and sexual dysfunction, phenelzine is the worst, and then tranylcypromine is a little bit better for most patients, and selegiline would be not expected with selegiline. Hepatotoxicity is possible with the MAOIs. You do want to be prudent and monitor liver function tests, but it's rare. It's not common, and it's not like with some of these other agents that have been withdrawn. The other adverse effects have to do with combining the MAOIs with other medications and with certain foods. So you want to be careful about hypertensive crisis and serotonin syndrome with the MAOIs. Those are two potentially fatal complications that result from combining MAOIs with certain medications and foods. First, I'll talk about hypertensive crisis. Hypertensive crisis occurs because there is an amino acid in the body, tyramine, which has catecholamine-releasing properties. It causes the release of dopamine and norepinephrine, epinephrine. And norepinephrine causes vasoconstriction in the periphery, and that increases blood pressure. So because of vasoconstriction, you get increased blood pressure, and if there's an excess of tyramine, this could be so much catecholamine release that you end up in a hypertensive crisis with blood pressure that is extremely high, malignant hypertension that is very dangerous. And this manifests as chest pain and shortness of breath and headache and nausea. Those are the early signs. In the extreme, it can lead to an intracranial bleed and death, and people did in fact die of intracranial bleeds early on before we knew of this potential complication from the effect of blocking monoamine oxidase on tyramine metabolism, because excess tyramine is metabolized by that enzyme. So if you block that enzyme, you can get a buildup of tyramine. And that in itself is not dangerous, but then if you eat a tyramine-rich diet, so now you have even more tyramine in the bloodstream. It's naturally occurring. It's not an essential amino acid. It's an amino acid that the body can produce on its own, and it does from tyrosine, which is another amino acid. If you eat certain foods and you're on an MAOI inhibitor, you could have a hypertensive crisis because of that. What are those foods? Cured or processed meats. The longer a food takes to process, the higher the tyramine levels. We're talking about dried meats like beef jerky. We're talking pepperoni, salami. Also smoked meats, fermented meats, meat that has been spoiled or improperly stored as well. Aged cheeses also cause a buildup of tyramine. Processed cheese slices are okay, cottage cheese is okay, ricotta is fine, cream cheese, but you want to avoid cheeses that undergo an aging process, high in tyramine. You want to stay away from the aged cheddars, etc. You also want to stay away from pickled or fermented vegetables, sauerkraut, kimchi. You want to stay away from soy products, tofu, and especially tempeh, and beer on tap and beer that's been unpasteurized. Canned or bottled beer is okay, and ethanol itself in a mixed drink is also safe. Other specific foods to avoid are broad bean pods, fava beans. All other vegetables are fine as long as they're not pickled or fermented. And overripe bananas and avocados are problematic. Banana peel is also often listed, although I don't know of many people who eat the banana peel, but it is very high in tyramine. So in case you ever wanted to chew on one while you were taking an MAOI, that's probably not a good idea. Low tyramine foods include fresh veggies, except for the broad bean pods, and generally all fruit, grains, eggs, non-fermented dairy. Yogurt is okay. Now, it has been suggested that adhering to a low-tyramine diet has been a little overblown. So there have been people that said, really, it's not that common. You would really have to eat a lot of pepperoni for this to happen, and it's probably not anything we need to worry about too much. Obviously, the people that it's happened to, some of which have died, that's a big deal. And so we want to err on the side of being cautious, and we would tell patients to adhere to a low-tyramine diet. Now, you might not have to worry about a low-tyramine diet if you are taking selegiline. Selegiline is unique among the MAOIs in that it can be a selective MAO-B inhibitor. And MAO-B, that isoenzyme, is mostly responsible for catabolizing dopamine. And so if you block MAO-B, then you get increased dopamine and not so much norepinephrine. And this means that there's less concern about hypertension and less danger of hypertensive crisis. So the oral form of selegiline, Eldepryl, is an MAO-B selective medication. It's actually approved for the treatment of Parkinson's disease, which is caused by a degeneration of dopaminergic tracts, motor tracts in the brain. And it's approved not for major depression, but for Parkinson's disease. Certain symptoms of the depression would improve for sure, but it's just not approved by the FDA. The transdermal preparation of selegiline, EMSAM, is approved for the treatment of MDD. And it's unique because it has a transdermal mechanism of action, for one thing. It's the only antidepressant I know of that is transdermally delivered. That could be useful if you have a patient who has trouble swallowing pills, or in an elderly patient with dementia who tends to refuse their medication. If you have authorization to give medication, you can just bypass the whole trying to convince them to swallow the pill. But it can be used in anyone who might have trouble remembering to take pills or swallowing pills. And if you deliver it transdermally, then you still get the MAO-B selectivity in the gut, where we would worry about the interaction with the tyramine and interfering with the catabolism of the excess tyramine. But in the brain, if you get transdermal selegiline, it's not selective, and so you get both MAO-A and MAO-B inhibition. You get all three neurotransmitters, serotonin, dopamine, and norepinephrine, and so you get the psychotropic effect that you want without the liability for the hypertensive crisis due to eating a diet high in tyramine. So EMSAM is special in that way. It can be very useful, and particularly, again, in patients who might have trouble adhering to that diet, people that really love their cheddar cheese and their salami. Charcuterie is definitely a no-no if you're on tranylcypromine or phenelzine. However, in overdose, selegiline is not selective anywhere. It has to be below a certain dosage for it to be selective in the gut. So even at doses that are higher than what are recommended, not necessarily due to overdose, but simply because we're off-label and we're trying higher doses to see if we can't get better efficacy, you do have to be concerned about tyramine-rich diets. Serotonin syndrome is another complication, and I also have a video on that. And It occurs when you mix medications that are serotonergic and a synergism takes place. There's too much serotonin, and that leads to an array of symptoms that includes a delirium, a hyperreflexia, and increased motor tone. There's twitching and tremor and myoclonus, and you could have a seizure, as well as autonomic instability, which includes hyperthermia, very high fevers, and high and low unstable blood pressure and a quickened pulse. You see agitation, you see confusion, you see sweating and dilated pupils, and it can be very dangerous. And this is most common when you combine MAOIs with other serotonergic medications. And the thing about MAOIs is that because they inhibit this enzyme irreversibly, it takes 2 to 3 weeks before that action can be corrected by the body. You basically have to make more enzyme. And so you don't have to taper these medications. You can just stop taking them. There's no withdrawal. But then for anywhere from 2 to 4 weeks, you're going to have continued effects. And the recommendation is that if you take an MAOI and you stop taking it, you have to wait 2 weeks. You have to have a 2-week washout before you can add another antidepressant if that antidepressant has significant serotonergic action. The same thing goes when you are taking an SSRI or an SNRI or another medication like mirtazapine that increases serotonin. You have to wait 2 weeks before you can initiate an MAOI. They cannot overlap by anything less than 2 weeks because of the danger of serotonin syndrome. And so that's all of the SSRIs, the SNRIs, venlafaxine and duloxetine. Mirtazapine is not an SSRI, but it's also on the list. You can use Wellbutrin, and you can use the tricyclic agents carefully, except for imipramine and clomipramine. Those are significantly serotonergic, and they could cause serotonin syndrome. The others, amitriptyline, protriptyline, nortriptyline, doxepin, those can be used cautiously. You can also use lithium. You can combine with trazodone carefully. Benzodiazepines are okay. And the third generation antipsychotic mood stabilizer agents such as Abilify, those can be used particularly as augmentation strategies to boost these medications. And here's what you need to know about MAOIs. Here's what's important about MAOIs, is that they are underprescribed, particularly if you're getting your antidepressant from a primary care provider and not a psychiatrist. But even psychiatrists are loath to prescribe them and will refer a patient with refractory MDD, major depression, that's not responding to treatment. They'll refer those patients to ECT a lot of times before they'll try the MAOIs. And part of that is because of all of this concern about having to be on a certain diet and taking the medications multiple times a day. Phenelzine has to be taken 2 or 3 times a day. And so they're inconvenient, and then you worry about serotonin syndrome. You have to do these long washouts before you can start them. So a patient who is very depressed, who hasn't responded to numerous medication trials and augmentation strategies, and here you are, if you've been doing it properly, you're 6, 8, 9 months, a year into treating this patient, and so you're going to wash them out and make them take no medication at all. Not that the meds are helping. Maybe they're helping a little. Maybe they're in partial remission, but they're still having a lot of symptoms. But now you want them to stop taking medications for 2 weeks so that you can try an MAOI that you can't combine with anything. I mean, it's probably why MAOIs are underprescribed. You probably haven't ever taken one, because if you have had trouble finding the right medication, or you have had to use more than one medication and you've had to switch and change the doses, your provider may not have recommended it to you because of all of these reasons. And so if you're somebody who continues to struggle, if you're only in partial remission, if you're just not getting the effect that you want, if you're not quite ready to consent for electroconvulsive therapy and some of these other therapies, you should definitely ask your provider about the MAOIs. They're underutilized. They are effective. They're not simply reserved for the treatment of treatment refractory cases because of all of these issues. There is evidence that they are better than some of these other agents. that they work better, and that if these other agents fail, that blocking the enzyme that breaks down those neurotransmitters is such a potent way of increasing them that you're going to get a better effect. So they're the most effective medications, particularly if we combine them, say, with the third generation antipsychotic agents or lithium, in order to really treat this treatment-resistant depression. So they should definitely be given a try. You should definitely stay away from pepperoni pizza and beer on tap, but a hypertensive crisis is probably not going to happen if you do that, particularly if you take EMSAM. And what you really have to be more careful about is not combining it with the medications that I've mentioned, as well as some other medications, including some opioid pain medications. Tramadol is the big one that's commonly prescribed. It has SNRI, serotonin norepinephrine reuptake inhibition properties, and it needs to be avoided to avoid serotonin syndrome. Dextromethorphan, which is the active ingredient in Robitussin DM, it's the antitussive agent in DM. It's over the counter. You can go and get it if your doctor doesn't tell you that you can't have dextromethorphan when you're taking phenelzine or tranylcypromine, or for that matter, selegiline. You don't want to take it. It has serotonin reuptake inhibition properties, and you can get an excess of serotonin, and you can get serotonin syndrome that way. And the tricyclics, clomipramine and imipramine, are serotonergic. The others you don't have to worry about serotonin syndrome with, but you do need to watch the blood pressure. And Wellbutrin's okay as well. St. John's wort, however, needs to be avoided. Ecstasy, in case you want to go to a rave, not a good idea. Highly serotonergic. Ecstasy all by itself in overdose can lead to serotonin syndrome. The amphetamines, cocaine, those can also cause a hypertensive crisis. You also want to be wary of over-the-counter decongestants. They also cause vasoconstriction and increase the blood pressure. They're not absolutely contraindicated, but you would definitely want to talk to your provider about the advisability of taking Sudafed. MAOIs are underutilized. They are a good choice for someone who is not improving and who can withstand a washout, and who can maybe take a medication several times a day and adhere to a special diet. So a high-functioning patient for whom ECT is less attractive, less desirable. I will say that ECT has the highest success rate, somewhere in the 90 percentile, and it's also much faster. MAOIs can take weeks and weeks before you reach remission. And an adequate therapeutic trial would be at least 12 weeks, 3 months, which is not to say that a person wouldn't start feeling better sooner than that, but it can take a long time. The medications, they have strange FDA indications. Tranylcypromine is indicated for major depressive disorder without melancholia. So that's very specific. And I would say, though, that what they're used for is treatment-resistant depression, treatment-resistant panic disorder, treatment-resistant social anxiety, treatment-resistant cases.